Welcome to Chapter 19. This is Lesson 19.1, Blood Chemistry. Introduction. Blood chemistry and serology tests. These are often performed in the medical office using automated blood analyzers that are designed for use specifically in a small medical office. They perform blood chemistry tests in a short period of time with fairly accurate test results. Blood chemistry is an analysis of the chemical substances in the body that are dissolved in the liquid part of blood, which is the plasma. Blood chemistry testing involves the quantitative measurement of chemical substances in the blood. So remember the difference between quantitative and qualitative. Quantitative gives us a quantity or the exact amount of a substance that is present. Serum specimens are what are required for most blood chemistry tests. So this is, both these tubes have been spun out in a centrifuge. This one with no anticoagulant, so the cells have clotted, but the serum gets separated from it. And then with an anticoagulant additive, the blood stays non-clotted. And then there's a buffy coat, and then the plasma is still separated during the spinning in the centrifuge. Quality control. This is methods and means that are done to ensure that test results are reliable and valid. So there's two really important QC or quality control measures that must be performed routinely. Calibration of any analyzers in the medical office, and then running controlled tests on the analyzers. So using a control is a sample with a specific known value, and they're often, made chemically, so we know exactly what value to expect when we run a control. So they're processed in the same way as a specimen, and we know that those results should fall within a specified range. And if the control test does not fall within that specific range, it means there's some sort of problem, right? There's either a problem or error with the analyzer, or it's malfunctioned. There's a problem with the testing technique, or there's a problem with the chemical reagents. So we can start troubleshooting there to make sure that we can fix it. So calibration is the act of checking or adjusting the accuracy of a measuring instrument. So this checks the precision of the analyzer, whatever it is we're using. If a machine is not properly calibrated, it can't produce accurate test results. So one thing that you probably haven't even realized yet that you use every time you come to the lab is the sphygmomanometer we use for checking blood pressure. Even those have to be calibrated. And if they are not correctly calibrated, then they will give you an incorrect blood pressure reading. So everything, all our equipment that we use has to be checked regularly. Okay, so cholesterol. This is a white, waxy, and fat-like substance that is liquid that's essential for normal functioning of the body, and it's a really important component of cellular membranes, and it's also used in the production of hormones and bile. So this is an illustration of an artery and some red blood cells in there floating through there, and also some cholesterol cells. So cholesterol circulates in the blood. It's manufactured mostly by the liver automatically, but also a portion of it comes from our diet as well. So this is dietary cholesterol. It's only found in animal products, so like organ meats, egg yolks, and dairy products, meat. There is no cholesterol in plant-based products. So the cholesterol level of any one person, that the amount of cholesterol floating around in their blood, is determined by their genetics. So that can determine how much cholesterol their liver makes. And then it's also determined by the amount of dietary cholesterol that they're eating and consuming, specifically saturated fat. High blood cholesterol means that there's too much cholesterol in the blood, and we do know that this causes atherosclerosis, which is a buildup of fatty deposits known as plaque on the walls of arteries. And as this progresses, the arteries become narrower and narrower until eventually they can close off completely. And that can lead to a heart attack or stroke. High blood cholesterol is a risk factor for coronary heart disease, or I call it coronary artery disease, CAD. So we do put out our best efforts to lower cholesterol because we know that that is something that we can do to increase a person's chance of living longer, honestly. So here's an illustration of a normal artery, arterial wall. There's no plaque on it. Here's a diseased artery with plaque built up along the inside of the walls, and then it's gotten so narrow that now there's a blood clot there. The blood wasn't able to pass through correctly. So there's two types of cholesterol that are transported in the blood as a lipoprotein. So lipoprotein is a complex molecule consisting of a lipid and a protein. So the two different types are low-density lipoprotein, or LDL, and then high-density lipoprotein, which is known as HDL. So LDL cholesterol is what's known as the bad cholesterol. So if you can remember L for lousy, that'll help you remember which is good and which is bad. So the LDL picks up additional cholesterol from ingested fats that we've eaten, and then also from the liver, and it delivers it to our blood vessels and muscles and then deposits it in the cells. As I said, that's often referred to as the bad cholesterol because an excess in the blood can cause the plaque to build up on the arterial walls, and it can result in atherosclerosis. HDL cholesterol is the good cholesterol. So if you can remember H for healthy, then that'll help you remember which one's good and which one's bad. The HDL removes excess cholesterol from the cells, so it doesn't get a chance to deposit there. It carries it to the liver so that it can be excreted from the body in our waste system. It's also protective and beneficial to the body, which is why it's often called the good cholesterol. So we actually want our HDL cholesterol levels to be high because that can reduce the risk of heart disease. And we want our, conversely, we want our LDL cholesterol to be low. So a low level of HDL, which would be below 40 milligrams per deciliter for men and 50 for women, that is also a risk factor for heart disease because it's not enough of that good cholesterol there to remove the bad cholesterol. So remember, we want high levels of HDL and low levels of LDL. So when we're interpreting the results of a cholesterol blood panel, we get the total cholesterol, which is just the total cholesterol is actually the LDL plus the HDL, and then you also add it to the triglyceride levels after you have divided those by 5, and then that's how you get the total cholesterol level. So desirable is you want it below 200 milligrams per deciliter, and then 200 to 239 is considered borderline high, and then over 240 is high. So the high category means that the patient has an increased risk for heart disease. Borderline high means that there's going to be an increased risk if there's other risk factors present, such as if the person is overweight or a smoker, or if they have a family history of heart disease. There's other things that increase the risk factors as well, diabetes, high blood pressure, lots of things actually. And then so when the patient's being prepared to get a blood draw to check their cholesterol levels, if it's just the total cholesterol and an HDL, fasting is not required, but it's usually a panel a whole panel, which will include a lipid profile panel, right? So that includes the total cholesterol, the HDL, the LDL, and triglycerides, which are also important. So for half of those, the patient needs to be fasting. So we usually just have them fast and get the whole profile done at once so they can get a nice good picture of all of the cholesterol, the different types and the levels. Triglycerides are the fat that are in the blood, and your body uses those for extra energy, but if you have too many, they get stored in case they're needed later, but really high levels of triglycerides are not good at all for our bodies, particularly the pancreas. It tends to cause pancreatitis and bad things. So we want, the total cholesterol to be below 200 milligrams per deciliter, and then we want the LDL to be nice and low, and we also want the triglycerides to be low, and the HDL to be high. So again, the triglycerides are a type of lipid found in the blood that your body converts those calories from the triglycerides, right, that it hasn't used into the triglycerides, and then those are stored in the fat cells. And then hormones release the triglycerides for energy between meals. So if you regularly are eating more calories than your body's burning, particularly carbohydrates and fats, you're going to have high triglycerides because they're going to get stored in that form. Okay, so let's talk about glucose. So this is an end product of carbohydrate metabolism. So that means, we're metabolizing our carbohydrates, and then at the very end, glucose is a product of that. So it's our main source of energy for our bodies, and our bodies want to maintain a constant and consistent blood glucose level to ensure a continuous source of energy for our bodies. They're very smart that way. So here in this illustration, you have an artery, you have the white blood cells, and then the red blood cells, and the little platelets, and then the little molecules of glucose there as well, floating around in the blood. So if we ingest more glucose than we need, it gets stored as glycogen, and it gets stored in our muscles and livers for later use for energy. So when no more space is available to store the glycogen, so we've completely filled up our glycogen stores, the excess glucose that we've eaten gets converted to fat and is stored as adipose tissue. So you'll often hear people say, glucose is bad, it's so bad, you don't want to eat glucose. Well, we need glucose to function and survive. I mean, literally, you can't, it's like trying to drive your car with no gas in it. So we have to have glucose to even move our bodies or use our brain or function at all. But you definitely don't want more than your body needs. And everybody's metabolic needs can be different, and they can change depending on your state of health and time in life. So it's kind of like trying to adjust that, to stay healthy is the tricky part, right? Especially since glucose usually tends to come in forms that taste pretty good. So something that we also talk a lot about when we're talking about glucose is insulin. So insulin is a hormone that is secreted by the beta cells inside the pancreas. And insulin is needed to be able to use the glucose in the body as energy, right? So it's what allows glucose to enter the body's cells and then convert it to energy. So it's really super important, right? We also need it to store our excess of glycogen in the liver and the muscle so that we can use it later for energy. So we do blood glucose testing to check the levels and see how our bodies are doing at utilizing the glucose, right? So this is a really common test to usually we're checking for diabetes, right? And so it's used to detect abnormalities in that carbohydrate metabolism. It can also indicate a condition called hypoglycemia, so low blood glucose, and then liver and adrenocortical dysfunction as well can affect the blood glucose numbers. So the testing comes in different methods. We can do a fasting blood sugar, which is known as FBS, and then we can do a 2-hour postprandial glucose test. Postprandial means after eating. And then we can do a glucose tolerance test, which is known as the GTT. So the fasting blood sugar is measured obviously when the patient's fasting. So a true fasting state means that they have not had any food or liquids for 12 hours. So anything other than water. And some places will tell you that black coffee is okay because it doesn't have any calories or glucose or anything like that that will affect the readings. But you want to be careful with that too. So really, I just tell people nothing but water for 12 hours before the test. So that evaluates, it just evaluates how well your body is, processing and using the glucose. So it can be used to diagnose diabetes, but usually it's used to kind of check in on the status of a diabetic patient, but you could use it as a routine screening as well. So if the glucose levels are high, then that means potential diabetes. So if the patient's fasting, you usually want to schedule that test for in the morning. So because people tend to get pretty cranky as the day goes on if they haven't eaten, since the evening before. So you think 12 hours, right? So if people have dinner at 7 p.m., by 7 a.m. the next morning, they're going to be hungry and ready for breakfast and cranky. So you want to get them into the lab or wherever they're going to be tested as soon as possible. So the fasting blood sugar normal range is 70 to 99 milligrams per deciliter. And then 100 to 125 is a little bit high, so that would be considered an impaired fasting glucose, which could be pre-diabetes. And then if it's 126 and up, that usually indicates, that's enough criteria for diagnosis for diabetes. But it would usually be followed up with additional testing. So running another fasting blood glucose, and then we'll talk about in a little bit a hemoglobin A1C test. So there's other tests that they'll do usually before assigning the diagnosis of diabetes. Let's just go back and talk about that briefly. So we're going to be checking this on ourselves in the lab. We're going to do a blood sugar test reading. And so if you want to get an accurate result, an accurate fasting result, then just keep in mind you want to come into the lab fasting. But if you're not able to, don't worry about it. We can still run a random blood sugar test, and that'll still give us a little bit of an idea of how well our body's processing it. So just keep that in mind. The 2-hour postprandial test is used to screen for diabetes and then monitor insulin dosages in patients that are already diabetic. So for this test, the patient fasts from midnight until breakfast, so no getting up, in the middle of the night to have a snack. And then the breakfast meal should have at least 100 grams of carbohydrates. So it's actually a lot. So they have to kind of add them up on what they're eating. So it's going to be, bread, toast with sugar and cereal and juice, orange juice or something else with a lot of carbohydrates in it and milk. Or the other option is they can get a kind of, it's probably a prescription actually, a drink called Glucola, which has 100 grams of carbohydrates in it, which is a lot more than a normal cola. And then they give a blood specimen exactly 2 hours after consuming the high carbohydrate meal. So we're testing, again, how well our body uses those and stores those carbohydrates. So in a non-diabetic patient, the glucose level should be normal, checking that specimen 2 hours after a really high carbohydrate meal. Normal people can process all of that within 1.5 to 2 hours. So in a diabetic patient, though, they're unable to do that. So the glucose level is not normal. It's still going to be very high, probably over 140 should be milligrams per deciliter. And so that would suggest diabetes and then would probably warrant further testing, possibly with the glucose tolerance test, the GTT. So this provides detailed information about the body's metabolism of glucose, and it can be used to diagnose diabetes, hypoglycemia, and then liver adrenocortical dysfunction. They also often do a test similar to this for as part of prenatal care for somebody who's pregnant to check for gestational diabetes. So I think we talked about this a little bit recently in that module. So fasting state, no food or drink, I would say probably 12 hours prior, drinking that really sugary glucose drink, and then testing the blood 2 hours later. And if it's high still, then that's a potential diagnosis for diabetes. One note is that, just a reminder, it's really important that your patient sits really, they have to just sit calmly and wait for those 2 hours between consuming the high carbohydrate meal or drinking the glucose drink, because if they're moving around, they're exercising, they're going to burn it off at a much quicker rate than if they're just sitting and resting. And so that's not going to help us know what their body's doing on average, right? So there's different forms of it, right? So for this one, they're going to have the patient eat a high carbohydrate diet 3 days before, and then fast coming in for the test for 12 hours. And then they take a fasting blood specimen and then a urine specimen, test them both for glucose. And if they're high, then that could indicate hyperglycemia, which would contraindicate administering a large amount of that glucose drink. So they might do this one first. It just depends, on the provider, honestly, and what their preference is. So if they pass, then they could drink the 100 gram of glucose drink. And then sometimes they'll even collect the specimens at different intervals, so that they know what a normal person, what their levels would be at, say 60 minutes after, or 120 minutes after, or 180 minutes, and then they can check the patient's levels at that time period against what they know should be normal, and see how they're doing, what their ability to handle the increased glucose is. So it's really important to make sure that each specimen is labeled with the exact time that they're collected, and that the patient's following those restrictions during the test. So, sitting quietly, no running around, no smoking, no eating, no drinking, all those things. It's really not fun. Yeah, so you can't eat or drink anything but little sips of water, because those will also affect the blood glucose levels. No smoking, as I said. The patient has to remain there and minimize their activity. Usually, you just recommend that they bring a book or, their phone, so they can listen to a podcast or something like that and just relax. There's definitely some side effects that are normal for patients to experience as their bodies are trying to metabolize these high levels of glucose, especially 2 hours and 3 hours in. So feeling weak and faint and perspiring is all normal. You just have to reassure your patient that it's normal, it's only temporary, it will pass. It's just due to the increase in the glucose levels in their body as the insulin is being secreted in response to that high glucose load. So recall that diabetics are not able to remove that extra glucose from their bloodstream at the same rate as non-diabetics, because their bodies are not making insulin in the right way. So for a non-diabetic patient, their blood glucose level is going to return to normal at each of those intervals, but that's not going to be the case for a diabetic. After they ingest the glucose solution, there's going to be high levels of glucose still present in their urine and in their blood, levels above normal because of the lack of insulin in their bodies. So management of diabetes. It's really, really important for diabetic patients to manage their condition well. And the main way they can do that is keeping blood glucose levels as close to normal as possible. So diabetic patients who maintain good blood glucose control generally experience fewer symptoms, and they can delay or prevent the long-term complications of the disease, which can lead to a longer life and a much better quality of life too, honestly. Diabetes is a very, very dangerous disease that people often underestimate. So tests for managing diabetes. 2 methods are usually used. The patient can self-monitor with a home blood glucose monitor, and that's usually called a glucometer. And then also they can get routine hemoglobin A1C tests checked. That has to be, it's normally run in a lab. We do actually have a little point of care unit that measures that in our lab that you'll get to use next semester as a level 2 with just using the capillary stick on the finger, and can give you the A1C results, which can be very helpful too. So again, home blood glucose levels are measured using a glucometer, and the results are displayed in milligrams per deciliter. And diabetic patients should keep a record of their test results, just so that their provider can review it periodically, and it helps assist them with their management plan, especially if they are self-administering insulin. That's usually based off of their home glucometer test results. So often the MA needs to reinforce the advantages of the blood glucose testing to the patient, because they have to puncture their skin, right? So the patient has to assume the responsibility for their self-management decisions. So we have to kind of help them feel confident in that. Glucometers are often used in the medical office. Reminder that they quantitatively measure blood glucose levels because they give us a specific amount. And the fasting blood sugar is the most commonly performed test using the glucometer. The 2 test strips are reagent, and then the results are displayed as a digital readout on the screen in milligrams per deciliter. Okay, so just a really quick little side note about diabetes. I mentioned that it's very commonly underestimated. Oops. And but it can cause a lot of problems. It's very, very dangerous. People can lose toes, feet, limbs, due to insufficient blood flow from diabetes. It gives us an increased risk for heart disease and stroke. People have gone blind from diabetes before, from just not managing their blood glucose levels, for a chronic time period. So we often call that just managing their sugars, or sugars are well controlled, or sugars are not well controlled. And especially over a long term, that can have devastating effects on patients. So it's really important that we, as healthcare professionals, reiterate that to our patients and encourage them to take charge of their own blood sugar levels when they're diabetic or pre-diabetic too. Okay, so the hemoglobin A1C test, this helps assess if the diabetic patient's blood glucose level is under control on a more chronic level, because this measures the amount of blood glucose over a 3-month time period. So it gives you kind of an average over 3 months, which is really great. So here we have a low hemoglobin A1C with very few sugars attached to the red blood cells, and then high, there's lots of sugars attached to the red blood cells, which is not good. All right, so those kind of collect cumulatively over about a 3-month time period. So this is known as glycosylation. That's the process of the glucose attaching to the hemoglobin on the red blood cells. And this occurs in all individuals. It's normal. And it forms a compound known as the hemoglobin A1C. So the amount of glucose that attaches to the hemoglobin is proportional to the amount of glucose in that individual's blood. So the more glucose in their blood, or the higher the glucose level, the more hemoglobin will become glycolated onto the red blood cells. So the higher the A1C level. So it's a really good way to check to see how well the diabetic is self-managing their blood sugar levels. The glucometer just gives us an instant reading of what the blood sugar level is at that second in time, but that can change quite frequently. So when interpreting these results, a normal A1C level without, in somebody who doesn't have diabetes, basically usually would be 4 to 5.6%. And then from 5.7 to 6.4% of A1C, that's an increased risk for diabetes or pre-diabetic. And then 6.5% and above is typically how an unmanaged diabetic, A1C level would be. But it is possible for a diabetic, who's managing their blood sugar levels well, they can drop their A1C level down to a normal range, with the use of, with the help of diet and insulin or other diabetic medications, right? So the ADA recommends that an A1C level of less than 7% for diabetics is what we're shooting for, right? Because then the patient has a better chance of delaying or preventing complications from the diabetes. So for every 1% drop in the A1C that a diabetic can lower it, there's a 35% reduction in the risk for the diabetic-related complications. So that's really huge, actually. That's a huge reduction for just a 1% drop in the A1C. It's pretty amazing. So here's some approximate conversion levels from, so for the A1C, if we're getting a result of 9, 10, 11, 12%, that means that the glucose level, which I'm used to seeing in milligrams per deciliter, is probably around 240 to 345, which is not good at all. 8% A1C with the 205 glucose is definitely cautionary. And so for a diabetic, if they can get their A1C to 6 or 7, that means that their blood glucose level is probably 135 to 170, then that's doing pretty good for them, at least according to the American Diabetes Association. So that is the end of lesson 19.1.